This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, cardiologist at UAB St. Vincent's.
All right, so welcome to MyHeart.net, and today we're going to discuss why obesity matters for kidney health. And with us, we have a Dr. Norman Seay, who actually goes by Winn, and he's assistant professor at the University of Alabama Birmingham. He studied at Harvard and then did his fellowship at Duke. So Winn, thank you for being here with us and try to enlighten us about kidneys.
Thank you for having me.
So, I think our main objective today, we intend, obviously with MyHeart.net, and here we are talking to a nephrologist, talking about the kidney. I think what we want to do, our main objective is, try to understand kidney health. We want to discuss a little bit of how obesity can affect your kidneys. We want to reduce the anxiety and build some awareness about chronic kidney disease. And finally, we want a patient to be more engaged and empowered by change that can occur when you do health style changes and do kind of healthy lifestyle, as well as some of the new development that has happened in the medical therapy. So let's start by maybe kind of enlightening us and tell us a little bit some basics. What do the kidneys do for our body, and why is it so important for our overall health?
Well, our kidneys do a lot of things. They regulate electrolytes in our body to keep them in normal range. Abnormalities in electrolytes can, among other things, make it hard for your heart to beat correctly, muscles to contract, or have the brain function properly. By adjusting the amount of urine we make, our kidneys prevent us from keeping excess fluid that would cause swelling and help us hold on to fluid when we are, for example, dehydrated. They filter toxins produced by our metabolism and remove many of the medications we take. They tell our bones to make more blood cells to keep us from becoming anemic. And on that note, they play an important role in bone health too.
Well, I think this is good. Whenever I see a patient and I'm just kind of see them for the first time, we go history, physical, then we review some labs, and we'll talk about lipids, and we'll talk about maybe some of the renal function that we have on the labs. We'll talk about the GFR in particular. And I say, oh, by the way, you look like you have chronic kidney disease stage 3. And they freak out. They say, what? Nobody's ever told me before. I feel fine. I don't feel any different. So, when clinicians talk to the patient about chronic kidney disease, if you could explain to us, and some kind of basic terms, what does it mean exactly? And maybe if you could enlighten us also into the kidney function as we age, because a lot of our patients, when we see Medicare patients, they're greater than 75 years old. Obviously, kidney function changes.
Yeah, so some really good questions. So in simple terms, chronic kidney disease refers to decreased cleaning function of the kidneys or persistent markers of kidney damage lasting 3 months or longer. There are 5 stages of chronic kidney disease based on someone's glomerular filtration rate, or GFR. Think of it roughly as someone's percent kidney function. Conceptually speaking, we lose kidney function as a natural process of aging. Like any organ, they don't last forever. Once someone's GFR drops below 60, they meet a diagnosis of chronic kidney disease, though they can also meet a diagnosis of chronic kidney disease when their GFR is above 60, but there's another marker of kidney damage, such as protein in the urine. The majority of people live with chronic kidney disease as opposed to dying on account of it, because it's not until our kidney function drops closer to a GFR of 15 or lower, that's 15, not 50, 15, that we more commonly see life-threatening complications of kidney failure. And on that note, most people with chronic kidney disease do not develop overt symptoms really until they progress closer to more advanced stages with the GFR below 30, if not closer to 15, again, before we'd expect to see symptoms of chronic kidney disease.
There's some people that are even proponent of as you get into your 80s and 90s and you get, GFR of 45 to 50, it's probably normal for their age. I mean, what do you think about that, Winn?
Well, it like I'd mentioned before, it's a natural process of aging to lose our GFR. So at least in terms of how we define chronic kidney disease, it still meets a diagnosis of chronic kidney disease if someone's 85 and has a GFR of 45. But I mean, not to sound morbid, but it's a very different conversation. Someone who's 85 years old with a GFR of 45 versus someone who's, say, 30 years old with a GFR of 45. And, their kidney function has to ideally last them the rest of their, the lives they had to live. And so you could argue that that patient with a GFR of 45 who's 85 years old, that the kidney function they have left to work with is not going to be the rate limiting step in terms of their longevity. It's probably something else, like a bad heart event, like a heart attack, that would probably be the limiting factor in terms of lifespan rather than their kidney disease.
I think that's a very good point. I mean, very few people with chronic kidney disease in their 70s or 80s that have, GFR in the 40, 45, and they're chronic kidney disease stage 3. It's rare they're going to progress to end-stage renal disease and end up with dialysis. But I guess from the cardiology standpoint, probably would be important, to know that you have chronic kidney disease because, half of those patients have already heart disease, kind of underlying heart disease. And as you mentioned, what's going to kill them is probably their heart.
Yeah, no, it's a very fair point. Someone who's 85 years old who, again, has a GFR of 45, it's important to note that they have chronic kidney disease for sure, but it's likely something that, that's the person I would expect would live with chronic kidney disease as opposed to dying on account of it. And so maybe less pressing for me to see as a kidney doctor that patient in clinic as, compared to that person who's 30 years old who already has a GFR of 45. That person I would be a little bit more worried about, 50 years down the road, getting to the point of kidney failure.
Right. Well, let's talk about obesity a little bit and how it affects your kidney health. I mean, we've seen since the 1970s, a growth in obesity, problem. And by obesity, we mean obesity as a disease, not only a BMI greater than 30, but when it affects also your health or your organs. And we're thinking about, sleep apnea. We're thinking about, HFpEF in patients that can't breathe, when they exert. We're thinking about getting metabolically unhealthy, getting a fatty liver. And now we're talking about kidney health. We've seen that growth, and now, 40% of the Americans, have a problem with obesity. We've seen that growth, kind of parallel to it, the growth in chronic kidney disease with maybe a diagnosis that was maybe less than 10% in the 2000, but now it's probably in the order of 13 to 15% of the US population, that have chronic kidney disease. And it's easy to imagine as the patients develop obesity or the problem with excess adiposity, they'll develop hypertension and diabetes. But here we're talking about, obesity affecting your kidney even before the development of hypertension or diabetes. How does, excess adiposity affect your kidneys, Winn?
Well, first and foremost, obesity is a risk factor for development of chronic kidney disease and is associated with worsening of chronic kidney disease down the road. Obesity-related kidney disease is a real thing. I mean, among other things, obesity is thought to be linked to an increased inflammatory state, causing release of what we call pro-inflammatory molecules that damage the blood vessels in the kidneys and can lead to scarring. Obesity can also cause the microscopic cleaning units in the kidneys to hyperfilter the blood, which can damage the cells that make up the filters in the long run. Even amongst patients with normal kidney function who are severely obese, if we sampled their kidney tissue and looked at it under the microscope, we might find signs of kidney damage. Obesity also increases risk for development of certain types of kidney stones, which can cause blockages. On top of all this, patients with obesity are increased risk for diabetes and high blood pressure, the most common causes of chronic kidney disease.
Yeah. So let's say, for example, you have this problem, a patient has problem with excess adiposities and they've determined to have chronic kidney disease. I mean, obviously your first step is really kind of advise them on healthy lifestyles. What do you tell your patient when when you have a patient with chronic kidney disease, or what should we tell them, as cardiologists?
Well, oftentimes patients meet a diagnosis of chronic kidney disease but have never been told they have it, which can be because providers are too busy or not comfortable explaining what it means to patients. And many patients I see in kidney clinic have no idea why I was asked to see them. And some patients without chronic kidney disease are at increased risk for developing it down the road, such as those with diabetes and high blood pressure. And, uh, chronic kidney disease is not a death sentence, but it's important to acknowledge that patients have it so they can start thinking about how they can set their kidneys up for success in the long run. A common, getting back to this, misconception I have to address the patients I see in clinic is that chronic kidney disease equates to a death sentence or a need to start dialysis. And sometimes because they were told they had kidney failure. And kidney failure, it's a strong term. I reserve it for patients with a GFR of 15 or less who are at higher risk for needing to consider dialysis. But among all comers with chronic kidney disease, only a small portion of patients will develop a need for dialysis. And to reiterate, most people live with chronic kidney disease rather than die on account of it. That's really how I would encourage providers to frame a new conversation. This is news delivered to a patient that they meet this diagnosis of chronic kidney disease. It's important to acknowledge it, but it doesn't necessarily amount to a death sentence. I would be careful using the term kidney failure because in my experience, that makes patients very anxious. For those who are at high risk for worsening of kidney function, there are lifestyle interventions and neuromedications we have developed that can substantially lower their risk for progression to kidney failure down the road.
How do you do that? There's certain things you need to avoid. What kind of healthy lifestyle changes, nutrition-wise or weight targets? How do you do that?
Yeah, so there's a lot of things to consider. And lifestyle interventions become all the more important with the diagnosis of chronic kidney disease, including exercise with the societal guidelines recommending 150 minutes of physical activity a week, and weight loss if you're overweight. Smoking both raises your blood pressure and can damage the blood vessels supplying your kidneys. So it's incredibly important to stop smoking. High blood pressure is very common in patients with chronic kidney disease, and when poorly controlled, can increase risk for worsening of kidney function. So these lifestyle interventions I've mentioned so far, as well as limiting salt intake, are even more important if you have high blood pressure.
Yeah.
If you take blood pressure medications, you should work closely with the doctor to come up with a medication regimen that effectively controls your blood pressure. And some types of blood pressure medications may be preferred over others if you have chronic kidney disease. If you have diabetes, blood sugar control between diet and medications is crucial. I also counsel my patients with chronic kidney disease to avoid medications called non-steroidal anti-inflammatory drugs, or NSAIDs. These include ibuprofen, naproxen, Aleve, Advil, BC powders, Goody powders, among others, because they can cause reversible and irreversible kidney injury. General rule of thumb is that in terms of over-the-counter medications for pain, Tylenol or acetaminophen is otherwise okay from a kidney perspective. And if your provider is prescribing you a medication for pain and you know you have chronic kidney disease, it would encourage you to ask your provider if the medication being prescribed is an NSAID. Because patients with chronic kidney disease can be at higher risk for bad heart events, ask your doctor if you would benefit from being put on a cholesterol-lowering medication to lower your risk for heart attack or stroke. As far as diet, a lot of patients ask me about low-protein diets. While our societal guidelines recommend it, these recommendations are admittedly based on a weak level of evidence, as there's no large clinical trials that have definitively answered the question of whether limiting protein intake preserves kidney function in the long run. That said, I don't discourage patients from opting for a low protein diet if they're willing to do it. And proteins such as fish, chicken, and plant proteins are preferred over red meat, if only from the perspective of lowering risk for cardiovascular disease. Dietary guidance really should otherwise be tailored to the individual. I don't recommend a generic renal diet, quote unquote, for example, restricts phosphorus and potassium intake in all of my patients with chronic kidney disease, as many patients I see have normal electrolytes despite their diagnosis of chronic kidney disease.
There's really some interesting medication that have been coming, for the treatment of chronic kidney disease, heart failure, and diabetes. Actually, they were first, um, brought to the market for the treatment of diabetes, and I'm thinking mostly the SGLT2 inhibitors like, the Jardians and the Farxiga, and now the newcomers, the GLP-1 receptor agonists. Tell us a little bit about, is this something that, tell us a little bit about the studies and, how strong do you feel about, starting the patient on SGLT2? What's your threshold? And we're always a little kind of nervous about the patients that have the chronic kidney disease stage 4. That means their kidney function is really getting, very, very, very much kind of affected. Their GFR between 20 and 30. There's good data showing that it's okay, but how should we do that in clinical practice?
Yeah, so as you mentioned, there are newer therapies that have been developed to slow progression of kidney disease. Now, note that it did not say cure chronic kidney disease. Generally speaking, in most cases, there's no magic bullet I have to give people back the kidney function that they've lost. The name of the game really is preserving kidney function that people have left as long as possible so they don't encounter kidney failure in their lifetime. For the longest time, we've commonly used medications called angiotensin converting enzyme inhibitors and angiotensin receptor blockers for many different types of kidney disease. And now, in addition to these medications, as you mentioned, there's a newer class of medications that have been shown to protect the kidneys called the SGLT2 inhibitors. The most common medications in this class being Farxiga and Jardians. And conceptually speaking, both the older and newer medications work in different ways to decompress the microscopic filtering units in the kidneys and preserve their integrity in the long run. And we know for sure that these medications are beneficial in folks who have kidney disease with significant protein in the urine. It's felt that they could be beneficial for patients who have mild or no protein in their urine. Though the data, I think, is more convincing for people who have a more significant degree of protein in their urine, which is essentially another marker of kidney damage. We know that based on the clinical trials that have been done to date, that patients with a GFR of 20 or above still benefit from being put on these medications. That admittedly, with the GFR below 20, it's a little bit of a black box studying or starting these patients on these medications because we just don't have clinical trial data that have proven whether or not that it delays progression to kidney failure for those people with the GFR below 20. With diabetic kidney disease, Ozempic or semaglutide has also been shown to protect kidney function, though we're still trying to figure out why. I suspect it's probably a number of different things: weight loss leading to better blood pressure control, better control of blood sugars, but there's likely some stabilizing effect on the microscopic filtering units in the kidneys as well. And I suspect it's what we call a class effect. While the Ozempic or semaglutide's been the only one that has had published findings of a clinical trial, I suspect other GLP-1 receptor agonists would probably, like Mounjaro or tirzepatide, would probably confer the same sort of benefit. So it's really some exciting promise in terms of newer therapies we have to further slow worsening of kidney function in folks with chronic kidney disease.
So when we start a SGLT2 inhibitor like the Jardians or Farxiga, they always mention, they stress the importance of hydrating well, and there's always a bit of a reduction of kidney function within the first month or two that seems to stabilize. And you look at these patients 2-3 years down the line, and they have a better kidney function than if they did not take it. Do you see? Is that what you find in clinical practice, Winn?
Yes, absolutely. And really, there's what we have to look at is the kidney function before and after starting the drug to make sure that there's not a unacceptable degree of drop in percent kidney function. And I counsel my patients as it's not that you're losing that kidney function. It's generally speaking a reversible effect of these drugs, the SGLT2 inhibitors and the ACE inhibitors and ARBs. But it's not that you're losing that kidney function. You're saving it for retirement, if you will. So we're thinking about the long run. Life is a marathon. We want to make sure we pace our kidneys out for the marathon that is life, so they make it to the finish line. So I, generally speaking, would not be, as a patient, discouraged if you start one of these medications and you see, oh my gosh, my GFR has dropped, it must be bad for me. This is an expected effect, is upfront. We shave off some percent kidney function, but save it for a rainy day down the road.
Yeah, I like that explanation. The GLP-1, it's kind of been very interesting, and we see in patients that have a lot of excess adiposity, where, first in the heart, for example, there's a lot of epicardial and pericardial fat, and I imagine the same with the kidney. You have a lot of fat that accumulates around the kidney that is thought to really kind of affect not only kidney function directly, but also maybe with hormonal factors like adipokines that got our triggers of inflammation, and could affect the kidney, and potentially by reducing that, the weight, even though sometimes it's not a very large amount of weight loss, there's really significant improvement in renal function. Really interesting, and how the field has evolved, in that respect.
Yes, as that sort of touched on before, I mean, I think it really is raises suspicion that there is something directly toxic about obesity to kidney function. And some of the things that you have mentioned are valid concerns, and the thoughts of renal fat deposition causing a sort of an obstructive picture that impairs the functioning of the kidney tissue. And again, this pro-inflammatory state of obesity leading to scarring, or what we call fibrosis. So I wouldn't be surprised if, say, 10, 20 years down the road, we find that there's much more to this than just better blood pressure control and better control of sugars that we see with these GLP-1 receptor agonists.
That's for sure. So listen, what message would you want someone that has excess adiposity and that has never been told he had chronic kidney disease? What's the takeaway from this discussion that we had today?
Yeah, I mean, as I mentioned before, obesity is a risk factor for development and progression of chronic kidney disease. It's just one of many other reasons why weight loss is so important. I mean, we have new drugs, in particular these GLP-1 receptor agonists, that have been shown to be effective at lowering weight and protective of the heart and kidneys, at least in patients with diabetes. I wouldn't be surprised if, as we started to study it in non-diabetic kidney disease and patients who are obese, that it would be beneficial as well. But we're still waiting for those clinical trials to happen and the findings of them to be published. A lot of patients tell me these drugs have changed their lives for the better, and just be open-minded to whatever your doctor may recommend, whether that be lifestyle changes or medications to treat your obesity.
Yeah. Winn, I mean, University of Alabama in Birmingham, really appreciate your insight, into kidney health. It's, we always kind of like, we're always scared when we talk about chronic kidney disease, and hopefully we've been able to kind of put away those fears, today, and really, if someone is told that they have kidney disease, maybe be an opportunity to really kind of like get your health, in check, and trying to be proactive and participate, in the treatment, because the patient has a lot to do with it.
Yes, all valid points. I mean, the first step is to acknowledge that you have it, but then take it as an opportunity to really think about the sorts of lifestyle interventions and medications that you can take on to change the outcome. And again, chronic kidney disease it's important to acknowledge, but it's not a death sentence or amount to dialysis for the vast majority of people. So thank you so much again for the opportunity to chat.
Yeah. Thank you, Winn. Appreciate Have a great day.
You too.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.